So this morning's session is to discuss the topic of uncontrolled hypertension. And as background, before we begin with the presentations, I wanted to address the reason for the topic to be discussed. So FDA is bringing this topic because there are manufacturers who are seeking indications for their product or products for uncontrolled hypertension in adults. Under the Pediatric Research Equity Act, FDA has the authority to require sponsors to conduct pediatric studies, but those studies, those requirements are limited to the indications being proposed for adults. In this case, what we're talking about is uncontrolled hypertension. Therefore, a discussion of the similarities or differences between adult and pediatric populations with regards to uncontrolled hypertension would be helpful to us. So to start out this morning's discussion, I'd like to call to the podium Dr. Pamela Z, head of the Pediatric Center for Excellence for Cardiovascular and Renal Metabolism from AstraZeneca. Thank you.
Good morning, everyone. I am so glad to be here this morning, and I think we can all agree we had a great session yesterday. And I'm looking forward to continuing the discussion this morning. So I'm Pamela Z, and I lead the Pediatric Center for Cardiovascular Renal Metabolism at AstraZeneca. And while pharmaceutical development can certainly focus on pediatric population primarily or even exclusively, as we just heard yesterday and even today, primarily the focus is on adults, and especially so in hypertension. The main target population is an adult one. And as we just heard, the FDA does have a requirement to assess product development in all pediatric age groups in order to support the adult marketing application. So our workshop hosts have wanted to start today's session with a recent specific example of an adult antihypertensive development program in the uncontrolled population before we go ahead and head into a discussion, a more general discussion on identifying appropriate pediatric hypertensive populations. So I'm going to do my best to represent the Baxdrostat team this morning, and I'll give you a very brief description of the Bax-HTN study population. So Bax-HTN is the phase 3 clinical trial for Baxdrostat, which is an aldosterone synthase inhibitor, which was recently approved for adults for the treatment of hypertension in combination with other medications to lower blood pressure when it's not adequately controlled on other meds. So there is some complexity to the Bax-HTN study design. There are multiple cohorts, there are 4 parts, there are multiple randomizations. And so because our focus today is really the study population, and in order to keep things simple, I will just tell you that that participants were randomized 1:1:1 to receive either Bax 1 milligram, 2 milligrams, or placebo. And that the primary endpoint was mean change in seated systolic blood pressure from baseline at 12 weeks. So then I'll skip through the study design, but I'll let you know that I've included a QR code at the end of these slides, so you can follow that. You can access the paper, which has a more detailed description of the study design, as well as a supplemental link to the protocol itself, if you're interested in more detail there. So what was the Bax-HTN target study population? Well, adults, and these were adults with uncontrolled or resistant hypertension. So specifically for the study, these were uncontrolled, this is uncontrolled hypertension on 2 medications, including a diuretic, or resistant on 3 antihypertensive medications, including a diuretic. These are largely primary hypertension. This is largely a primary hypertension population, and this is reflective of the unmet medical need in the adult population. So safety and mechanism of action as an aldosterone synthase inhibitor really drove inclusion-exclusion. So you'll see parameters for potassium and sodium, renal function. You'll also see concomitant medications that were prohibited, which also suppress the aldosterone pathway, like MRAs. And as far as secondary hypertension exclusions, like renal artery stenosis and uncontrolled diabetes, there were concerns for acute kidney injury. So other causes of secondary hypertension, where the primary treatment was really treatment of the disease itself, like uncontrolled thyroid disease or FeO, those were excluded as well. So for the target study population, really, you see unmet medical need, mechanism of action, and safety driving the inclusion-exclusion. So who were actually enrolled? Well, the population is obviously an adult population. So mean age is 60, 61. And you see about a 30% uncontrolled hypertension population, about a 70% resistant hypertension population. These patients were drawn globally from the Americas, from the Middle East, from Europe, from Asia Pac, and from Africa. So you also see here that the participants were on a median number of background medications of 3. And most of these were on an ACE or an ARB. Also, most of them were on a calcium channel blocker. About 50% are living with obesity, and 38% had diabetes. So that gives you a flavor for the target patient population in Baxdrostat. What I did here was include a snip from the U.S. prescribing information. So you see here that Bax was indicated for the treatment of hypertension in combination with other antihypertensives to lower blood pressure in adults who are not adequately controlled on other medications. So this may help inform our later discussions when we talk about identifying a pediatric population. And then, as promised, here is the code to the QR code, which will link you to the article. I believe these slides will be available in a couple of weeks. I think I give this over now to Dr. Baker-Smith.
Hi, everyone. Welcome. Thank you, Dr. Z, for your presentation. So I'd like to welcome Dr. Carissa Baker-Smith. Dr. Baker-Smith is a professor of pediatrics and director of research and director of preventive cardiology at Nemours Cardiac Center in Wilmington, Delaware. She's going to speak to us today about the similarities and differences of uncontrolled hypertension in adult and pediatric patients.
Well, good morning, everyone. Thank you for this opportunity. I've enjoyed this conference workshop, I should say, tremendously. And I think a lot of the dialogue that has taken place will definitely help us to advance care of children with hypertension. With that, these are a few of my disclosures. I have no financial relationships that impact the topic of this presentation. So in the short time allotted, I want to review the importance of addressing uncontrolled hypertension and treatment-resistant hypertension and what we know. To discuss the difference between the two, review definitions of uncontrolled hypertension and treatment-resistant hypertension in adults and children, as well as I want to take a step back and actually think about the social ecological models of health that are important for us to consider as we think about evaluating both adults and children with uncontrolled hypertension. We'll review the known etiologies, including the pathophysiology, compare and contrast similarities and differences in uncontrolled hypertension and treatment-resistant hypertension across the age spectrum, as well as methods for assessing these two conditions. And then it'll be a nice setup for my colleague, Dr. Brady, who will talk to you about treatment. So we know that addressing uncontrolled hypertension is important, especially that it's a multiplier for risk for cardiovascular disease, meaning stroke, myocardial infarction, and advanced stages of cardiovascular kidney metabolic syndrome. About 40% greater likelihood of suffering a combined outcome of death, myocardial infarction, heart failure, stroke, or CKD over a median of 4 years, and a twofold increase of cardiovascular events in patients who have true treatment-resistant hypertension versus those who are antihypertensive medication responders. Some of the foundational work, and I won't go into all of the studies that have laid the foundation for this relationship, but I do think it's important to highlight the Framingham study, which was one of the first studies to illustrate to us the importance of hypertension as a precursor and risk factor for cardiovascular disease. We do have some study from the National Health NHANES in nutrition survey, which looked at time to event and probability of survival in those who have no hypertension in the purple versus treated and controlled in the green versus those with treated and uncontrolled or untreated. You can see that survival is much poorer for those who have uncontrolled or untreated hypertension. Similarly, if we look at just cardiovascular disease isolated, outcomes are poorer, and then heart disease as well, cerebrovascular disease as well. And so in this study looking at office measurements, so NHANES doesn't allow for out-of-office blood pressure assessment. It is in office in a single visit. But those who had treated and uncontrolled hypertension do have a significantly greater odds of cardiovascular disease, all-cause events, heart disease, and cerebrovascular disease. So uncontrolled hypertension versus treatment resistant, what is the difference? Well, you have uncontrolled hypertension if the blood pressure is greater than or equal to goal on medication or off, right? I guess it's uncontrolled if you're not being treated. And were there secondary causes of hypertension diagnosed and treated? It's a question to ask. Were appropriate therapies prescribed? Are the prescribed therapies being taken as recommended? And were the therapeutic doses optimized so that they were receiving 3 or more agents, including a diuretic in adults, or blood pressure was controlled on 4 optimally dosed medications? And if the answers to this are yes, but blood pressure is still greater than goal, then you have treatment-resistant hypertension. So there are some categories that I think we need to consider. The first is this idea of pseudo-uncontrolled. So that is blood pressure is greater than goal based upon office blood pressure alone. And as we've talked about, it is important to assess, particularly in children, their out-of-office measurements. And then there's mass uncontrolled, where the blood pressure is greater than goal based on home blood pressure. So in adults, that can be an oscillometric home blood pressure monitoring device or ambulatory blood pressure monitoring. Although I will say the 2025 hypertension guidelines do recommend home blood pressure over ABPM. And then in kids, we do not have approved protocols for home blood pressure assessment and do rely on ABPM. So in terms of categories and diagnosis of uncontrolled high blood pressure, normal blood pressures are less than 120 over less than 80. There can be elevated 120 to 129, less than 80, diastolic, and then there's stage 1 and stage 2. There are also categories when we think about, again, this idea of sustained normotension, sustained hypertension, masked hypertension, white coat, controlled and uncontrolled, and then masked and uncontrolled hypertension. And then in the current guidelines, there are some cutoff values that we use based upon whether or not the blood pressure has been assessed at home or via ABPM. There are no established definitions for uncontrolled hypertension for kids. So when we did the 2017 guidelines, I had the opportunity to be one of the lead co-authors of that guideline. We did not have a definition. So I'm going to take a moment here and just kind of contextualize what many of us as clinicians experience. We think largely in medicine about the individual factors, but we must consider there are interpersonal factors, the relationship between the child and the parent. Obviously, sometimes the children are dependent on their parents for administration of their medications, community factors, and then societal factors. And this is important no matter what medical condition we're thinking about, because frankly, our care and our health is not isolated to us as individuals alone, but often is driven 80% of the time by things outside of our immediate genetics, if you would. So in terms of uncontrolled hypertension in adults, 50 to 80% of adults prescribed antihypertensive therapy do not take as prescribed. And this may be due to large pill burdens, dosing complexity, expense, high frequency of adverse reactions, poor patient-clinician relationships, clinician inertia when there is evidence of elevated blood pressure, and then higher prevalence of things like social constructs that may impact outcomes, obstructive sleep apnea, and then there can be other comorbidities. We, several years ago, when I was looking at antihypertensive use in kids, we did a study where we used the electronic health record to determine how many kids actually required more than one medication. The primary purpose of the study was to look at antihypertensive therapies and what agents were used most commonly. You can see here ACE inhibitors were frequently used, and this was for cardiology and nephrology managed kids with hypertension. But we did find that about a third of children, a quarter to a third, had poorly controlled and were prescribed 2 or more medications. To the best of my knowledge, there hasn't been a substantially number of increased studies, a number of other studies looking at the kids who actually receive more than one therapy and get close to a diagnosis of resistant hypertension. So treatment-resistant hypertension is, again, defined in the adult population quite clearly. There are some differences if you look at European versus U.S. Definitions, but here in the U.S., this is how we define treatment-resistant hypertension. It is blood pressure greater than goal with the use of 3 antihypertensive therapies, including a diuretic, at maximally tolerable doses, and all prescribed at maximally effective doses. And then blood pressure at goal requiring 4 or more antihypertensive therapies to do so. And again, in pediatrics, we do not have a diagnosis for treatment-resistant hypertension diagnostic criteria. We use adult criteria. So about 12 to 18% of patients receiving antihypertensive therapy have treatment resistant in adults, is estimated. And there's several presumed pathophysiologic reasons for that, maybe related to endothelin-1 elevation. This can happen in cases where people have OSA and obesity, vasopressin elevation, which leads to elevated total peripheral vascular resistance, arterial stiffness. There can be a remodeling of the small vessels and increased peripheral vascular resistance and thus increased blood pressure. We know that obstructive sleep apnea is a secondary cause of hypertension, but also may be associated with treatment resistant. That is sympathetic overdrive, RAS activation, endothelial dysfunction, fluid retention, and with a 2.84 or greater odds of treatment resistant hypertension in adults with OSA. And then, of course, as I mentioned, and you think about the social ecological framework, social factors, deprivation, influenced indices such as obesity and diabetes. And what I mean by that is where I live, how I live influences my risk for things like obesity, higher stages of cardiovascular kidney metabolic syndrome, and even diabetes. For children, this is a case, this is an article that was published by Dr. Flynn. We don't have a great sense of the prevalence of treatment-resistant hypertension. There have been some case reports, but again, the steps to making that diagnosis are as I've described. So interplay of normal hormonal pathways leading to inappropriate aldosterone excess, again, leading to volume and sodium overload, increased arterial stiffness, even kidney fibrosis. The central mechanism, though, is aldosterone excess, potentially in adults. Primary aldosteronism, as we know, is a most common secondary cause of treatment-resistant hypertension in 5 to 25% of cases. There's RAS resistance in some cases. And then it's also important to distinguish treatment-resistant from refractory. Treatment-resistant driven by volume overload and aldosterone excess versus refractory hypertension where 5 or more drugs, including a thiazide diuretic or mineralocorticoid receptor agonist due to hypersympathetic output and normal aldosterone levels. The treatment in this case is an alpha beta blockade and centrally acting sympathome inhibitors. So this is a nice article, New England Journal, just summarizing some of the pathophysiology, and I won't get into the treatments associated with managing treatment-resistant hypertension, as that will be covered in the next talk, but I did want to share this central illustration with you. So in pediatrics, it may be multifactorial. There may be related to diet. The elimination of substances known to increase blood pressure are important. Identification of other secondary causes. There's volume and sodium overload. Again, salt sensitivity may be a particular issue, especially in children with chronic kidney disease. There may be renin, angiotensin, aldosterone system dysregulation, and then activation of the sympathetic nervous system, again leading to renal sodium retention and vasoconstriction. And then, as we've talked about, insulin resistance and obesity being a very important contributor to treatment-resistant hypertension. So obesity leading to endothelial dysfunction, insulin leptin resistance, sodium retention, increased sympathetic nervous system activation, cardiac ectopic fat, increased arterial stiffness. There's decreased arterial compliance and increased SVR. So all of the things that can also contribute to cardiac dysfunction and downstream outcomes that we seek to avoid. When we're considering treatment resistance, again, incorporating this idea of not only the individual, but also these social ecological frameworks, proper measurement. This is done poorly in kids. We know this. Often practices do not have the proper materials, cuff size and the like, to properly assess blood pressure. Interpretation was a barrier that we sought to address with the 2017 guidelines, including phrases like .bpfa and EPIC, so that if a percentile was required for diagnosis, it was easier for the provider to obtain that without having to look through cumbersome tables. Then diagnosis and treating secondary causes. And then, as we all know, for those of us who take care of adolescents and young kids, treatment adherence being a very important contributor. So consideration of the secondary causes, think about renal parenchymal disease and renal vascular disease. Of course, couldn't be a pediatric cardiologist. I'd be remiss if I didn't mention coarctation of the aorta and also mid-aortic syndrome. At times, we do have patients that have gone missed with those conditions, and we see them later. Endocrine disorders, including pheochromocytoma, monogenic forms of hypertension, drug-induced hypertension. Think about the out-of-office assessment. Again, we want to not include pseudo-resistance. We do want to get to those who have true treatment-resistant hypertension, and so that does require getting some out-of-office measurements. This is recommended from the 2025 AHA-ACC guideline. So as I mentioned, I won't reiterate this, but just getting back to the fact that approaches for assessing out-of-office hypertension does mean using an ABPM in pediatrics, as yet we do not have home blood pressure protocols. The last thing I want to close with is this was a prospective study of about 556 individuals where they looked at the relationship between white coat resistant hypertension, so that pseudo-resistant hypertension group, and true resistant hypertension. And there are differences in outcome when you look at total cardiovascular events. So a much higher likelihood of a total cardiovascular event, including like heart attack, stroke, in those with true resistant hypertension versus white coat. So getting to the point that we do need to get accurate out-of-office measurement. I'm going to skip over this one. And so just a couple of things. Our gaps, I just added a few things here. We can certainly discuss that there are more. We talked about trajectories of blood pressure. One question I have is, can we, by treating hypertension early, can we reduce the likelihood of treatment-resistant hypertension in adults? Pseudo-resistant hypertension, is there a benefit to addressing that in kids, thinking about comorbidities that might advance the pathophysiology of treatment-resistant and is treatment-resistant hypertension in children primarily driven by excess aldosterone as it is in adults or by heightened sympathetic output, because that will impact what types of therapies we consider for them and whether or not they align with what's being used in adults. So in conclusion, uncontrolled hypertension and treatment-resistant hypertension are associated with a significantly greater risk of cardiovascular disease and thus critical targets for improving cardiovascular health and for lowering long-term cardiovascular disease risk across the lifespan is critical. We must think about the social ecological models of health, and these risks should not be ignored. Definitions are less well defined in pediatrics, and currently we use adult definitions, so there's an opportunity. The pathophysiology, when not related to social factors, may differ in adults versus children. We have limited data. And diagnosis should include the measurement of out-of-office blood pressure, home blood pressure for adults, and ABPM for pediatrics and adults. And with that, I thank you for your time.
Thanks, Carissa. So the next presentation is by Dr. Tammy Brady. Dr. Brady is pediatric nephrologist and medical director of the Pediatric Hypertension Program at Children's National Health System here in Washington, D.C. And she's going to talk to us about the response to treatment in patients with uncontrolled hypertension in adults compared to pediatric patients.
Okay, thank you and good morning. I'd just like to echo what the speakers before me have said about how amazing this workshop has been. I've learned a ton. I've been just taking tons of notes. I have all the ideas, so I'm really grateful for this conference and that I get to participate. And so I have the unlucky job of following Dr. Baker-Smith, but she really did set me up for success by giving an amazing introduction to this topic. So I have nothing to disclose. And so for my talk, I do want to review a little bit of the nuance between uncontrolled and resistant hypertension, not to be duplicative, but just to add on to what Dr. Baker-Smith just informed us all about. And then I'll summarize the efficacy of the newer meds that are approved for uncontrolled hypertension, and you'll see the majority of them are in adults. And then introduce some maybe adjunctive approaches to improve hypertension control, particularly in pediatrics. And so, as Dr. Baker-Smith said, there's really no reference to uncontrolled hypertension in the clinical practice guidelines. To the left, this is from the 2025 adult guidelines, and you'll see highlighted there's multiple times where they mentioned uncontrolled hypertension and how to approach it, how it's defined, things to consider. But again, we really don't have anything yet in the guidelines available to us as pediatricians. Now, there's various causes that Dr. Baker-Smith highlighted, and so this is from adult data, but I think it's important to sort of emphasize this again, because these are some of the things that I'm thinking about in my clinic when I have a kid who comes in who's on a bunch of meds and their blood pressure is still high. So in adults, most of the or at least half of the causes of uncontrolled hypertension is related to non-adherence. And so I think I have been a part of multiple studies where we look at patient-provider communication, and I think that this is something, at least in the pediatric space, that really isn't consistently discussed and discussed, in terms of side effects and things you like and don't like about medications. And so knowing this is a big part of uncontrolled hypertension in adults, this lends itself to further conversation in pediatrics. White coat hypertension also could be a cause. Their out-of-office blood pressures may be very well controlled, but they may be, especially in pediatrics, nervous about the blood draw, the vaccines, what have you, and their blood pressure may be higher in the office. What we tend to think about a lot in kids is undiagnosed secondary hypertension. That's sometimes my threshold for doing more invasive procedures to determine if they have renal artery stenosis or something else. And in 5 to 25% of adult cases, that's the cause of uncontrolled hypertension. And then we then get to resistant hypertension, which is maybe around 10% of adult causes. But the thing I want to highlight here, because I think this comes particularly into play in pediatrics, are sometimes it's resistant due to associated comorbidities, right? These may be individuals who have comorbid obesity, diabetes, CKD, OSA, and they may be taking other medications to control some of these conditions, such as NSAIDs, antidepressants, or even illicit substances. And so, again, there's a lot more guidance in the adult guidelines. And so taking from this, the treatment in adults really should be a combination of the following. And again, I think we all as pediatricians kind of do this on the regular, right? So lifestyle, revisiting the importance of lifestyle changes, because those should always be first line and continued even after medications are prescribed. Talking about combination pills, I think this is definitely something that we as pediatricians can do better with in prescribing, because kids don't like taking lots of meds. And in fact, I will just anecdotally share, I had a patient who was on 3 medications. His blood pressure, again, remained elevated. I had a conversation, and it turned out he just hated taking the 3 meds. I gave him a combo pill with all 3. Y'all, his blood pressure was like almost 50th percentile. And so then we started weaning one of the doses in the triple combination pill, and he didn't feel defeated anymore. He felt excited. He was proud. And so I think that we can really kind of think about it. It was really simple for me to do, right? 1 prescription, actually easier, 1 prescription instead of 3. So other things, intensified diuretics, they have a lot more experience and instructions, I should say, in the adult guidelines. And then 4th line agents, which I think is what we're kind of talking about here. Beta blockers, alpha blockers, and some other newer blockers like for instance, the dual endothelin receptor antagonists. And so again, here's just another example of how the adults are a little bit more equipped to handle uncontrolled hypertension. This is a table from the guidelines with lots of different agents that you can use, the mechanism of action, and dosing recs, and how they might lower blood pressure. All right, so let's talk a little bit about the medications that are used to treat hypertension and uncontrolled hypertension. And so we have some newish meds on the block, right? And so these are the direct renin inhibitors, aldosterone synthase inhibitors, endothelin receptor antagonists, and angiotensinogen inhibitors. And you'll see in this figure that, in this figure, I've tried to indicate where their mechanism of action is. So, and I just put this here because these are our old friends. These are the ones that we typically use, and the sites of action. And so I'm going to go through a little bit with these newer meds, which you can see here where they have their sites of action. But you'll see, so only one of these is approved, FDA approved for hypertension. The other 2 that are approved by the FDA are for uncontrolled hypertension. And as I last looked, the angiotensinogen inhibitors are not yet FDA approved. So the direct renin inhibitors, so aliskiren is the only orally active one approved for clinical use. And the nice thing about this medication, especially when I'm thinking about my pediatric patients who don't like to take meds, if I can give them a med that you can give once a day instead of twice a day, it's going to be much better. It has a long duration of action with a half-life and elimination of about 24 hours. And it has similar blood pressure lowering as ACEs and ARBs. And so this is some adult data. You can see when you compare aliskiren with placebo, with increasing dose, you have greater blood pressure reduction, both from a systolic and diastolic standpoint. But in peds, there's limited but some emerging evidence. And just like with our ACEs and ARBs, we need close lab monitoring to make sure that the potassium and the creatinine don't go too high or in an unsafe range. It is in peds not considered to be first line, and really should be reserved for cases where the standard therapies are ineffective or not tolerated. But it's lovely that we have some dosing recommendations, because sometimes, as we've talked about with off-label use, we kind of gestalt it and kind of don't have such clear guidance. And so I just put this here to share that there is guidance for pediatricians for prescribing this medicine. And then this was, like as I mentioned, there's some emerging evidence. And so in this 8-week randomized double-blind trial in pediatric patients who were 6 to 17 years of age, you'll see that there was an increase with increasing dose, greater reduction in systolic blood pressure, although not quite as robust as what was seen in adults. So moving on to the aldosterone synthase inhibitors. So these are orally active, and we just heard a little bit about one of them that's given once daily. These are relatively newer agents, and they are highly selective for the aldosterone synthase receptor. And as a result, there's minimal effect on cortisol. Some of the earlier agents that were less selective also inhibited cortisol synthesis. And so there were lots of side effects. And so with these newer agents, there's a decreased risk of adrenal insufficiency. And so I'm going to share a little bit about lorundrostat and then briefly go over Baxdrostat since we've already heard about it. But this was from the more recently published, I think it was last year, comparing lorundrostat with placebo. And this was an add-on therapy. So the adult participants in this trial had treatment-resistant hypertension, already taking 2 to 5 meds. And so then they were randomized to taking lorundrostat or placebo. And you can see that their mean change in systolic blood pressure at week 16 was quite robust, with the least squares between group difference being 9 millimeters of mercury. And we just heard about Baxdrostat. And so here you'll see that in comparing to placebo, the difference in blood pressure reduction from 1 milligram to 2 milligram wasn't quite, large, but there is, going up, decreasing your blood pressure by 10 millimeters of mercury can be a real game changer for individuals. However, these medications are not studied in children, and so right now are not recommended for use. So, speaking as someone in the field, like this would be great to have another tool in my toolbox. So moving on to there are endothelin receptor antagonists. And so as as Dr. Baker-Smith highlighted, that perhaps some of uncontrolled hypertension is related to endothelin-1 being, continuing to be active because nothing yet is targeting it. So endothelin-1 is a vasoconstrictive peptide upregulated in resistant hypertension. The receptors are on the vascular smooth muscle and the endothelial cells. The ETA receptor, when it's activated, causes vasoconstriction and has proliferative effects. But the ETB receptor causes vasodilatation via release of nitric oxide and prostacyclin. So those dual antagonists inhibit both, which doesn't allow you to take the benefit of the ETB receptor activation, whereas the ETA receptor antagonists selectively block the vasoconstrictive and proliferative effects of endothelin-1, and again, preserves the beneficial ATP-mediated effects. This is also, again, because it's meant for uncontrolled hypertension. It's not first line, it's adjunctive therapy for those who are not adequately controlled. But the nice thing is that these don't increase heart rate or activate the RAS system or the sympathetic nervous system. Again, not studied in children and not recommended for use. So again, it would be great to have this tool in our toolbox at some point. And then emerging is the RNA-based angiotensinogen inhibitors. So these use small interfering RNA technology to silence the hepatic angiotensinogen synthesis. The cool thing, or maybe not cool thing, for depending on the kid, because they may not like shots, but you give it once and it can last up to 6 months, right? And so these kids who are really struggling every day to take meds, if they can just come into the doctor's office and get this medication, this really could be a game changer in pediatrics. And so this was a study that was published in 2024, looking at the effects of using this agent in adults with mild to moderate hypertension. And you can see in the box below the least squares mean difference versus placebo in the change in blood pressure. And you can see that there's quite a significant decrease in the systolic blood pressure with the use of this agent. And then they had another study that was recently done that was using this agent as an add-on treatment for those with inadequately controlled hypertension. So that an open label run-in treatment for more than 4 weeks with at least once daily indipamide, amlodipine, or olmesartan. And then interestingly, adherent patients with 24-hour mean ambulatory systolic blood pressure that were between 130 and 160 were then randomized to receive zilebesiran or placebo. And what you can see, interestingly, is that this add-on therapy decreased blood pressure in all of the groups, but it was much more profound of a drop with the diuretic versus the ARB. And so, and thinking about potential, combination drugs, I think that this just tells us that we really do need to see the efficacy in certain combinations because they may work differently than others. Okay, so now I'm going to talk about some of the more adjunctive meds for kids. So these are medications that aren't necessarily blood pressure lowering medications, but do have blood pressure lowering properties that may be independent of its other mechanism of action. And as I mentioned earlier, uncontrolled hypertension, one of the biggest causes are these comorbid conditions such as obesity and diabetes. And so with these agents, particularly if they're used in combination with blood pressure medication lowering agents, could really be very useful potentially. So the SGLT2 inhibitors, or the flozins, are indicated in peds for improved glycemic control, individuals with type 2 diabetes who are 10 years of age or older. And then the GLP-1 receptor agonists, also for glycemic control, type 2 diabetes and above 10. But they also have an additional indication for individuals with obesity, 12 years and above, who are also implementing lifestyle changes. And again, so they, in adult data for the SGLT2 inhibitors, they do lower blood pressure, systolic by up to 5, diastolic by up to 2. And the thought is that the blood pressure lowering mechanism is certainly due to weight loss, but also natriuresis, osmotic diuresis, and reduced arterial stiffness. And so, again, you're getting several bangs for your buck there, I think, in terms of helping with their obesity, diabetes, and blood pressure. GLP-1, in some peds studies, they lower systolic blood pressure by 2 to 3 millimeters of mercury in those with obesity or diabetes, minimal to no effect on diabetes, and again, similar mechanism of blood pressure lowering, although it may also reduce sympathetic nervous system activity and improve endothelial function. And again, going back to combo meds, so these are the adult guidelines, and they really very strongly advocate for this, both for initial therapy in individuals with elevated blood pressure above 140/90, thinking you come in high, you're likely going to need more than one agent. Let's just treat this initially with 2 meds, half of the usual dose in a combination to really try to get some good blood pressure lowering right from the get-go. And then for those who have issues with adherence and certainly in uncontrolled hypertension, using this to kind of improve adherence and improve blood pressure control. And the studies have shown that with this strategy, you can have better medication adherence. I certainly have seen that anecdotally, as I've shared, greater reductions in blood pressure and higher rates of BP goal achievement versus using a single pill. And I will say also anecdotally, it can be, and I mentioned this, I think, on the panel yesterday, if you have high blood pressure and you start low, titrate up, which is what the BP guidelines say for kids. And, I start on amlodipine of 5 and, okay, I got 2 millimeters of mercury reduction, come back in a couple weeks and we'll go up to 10 and get maybe another 1. It's frustrating. And, but if you can start right from the beginning and get them really close to goal, and have something to celebrate, I think that there's a lot more buy-in, and it can be easier to communicate with your families. Again, this is sort of my opinion, but I have seen it, the families that are frustrated. So there are quite a few, again, it's from the adult guidelines, but antihypertensive meds in fixed dose combination available in the US. But I put this here also to say these are fixed dose, right? And so in peds, a lot of the things in peds are based on weight. And so I'm often, when I'm trying to make this transition to single pill combination, forced to adjust the dose that I really want to give them, and kind of making some decisions. Do I want to give a little more of the ACE? Do I want to give a little more of the calcium channel blocker? And so it would be great if there were more pills available with different dosing, to make it easier for pediatricians to do this. So Josh stole my thunder a little bit earlier yesterday, but this is, I think this is a really compelling systematic review and meta-analysis, and I'm going to go quickly through it since he already went through this, but for me, this is very powerful, right? So again, in peds, the dogma is start low, titrate up, right? So I get a kid in my office, I give them the start in a 50, I lower their blood pressure by 7. Oh, okay, we still need a little bit more. Let's double the dose to 100. I get 1 more millimeter mercury lowering, right? Frustrating. Or the same thing with lisinopril. I mean, you increase the lowering by 3. If I use metoprolol, which I don't really do, but I don't really get any difference by increasing or doubling the dose. And then same thing with amlodipine. I get a little bit more, but not quite what normally I'm hoping for. Now contrast that. So if I start you on losartan of 50 and then I add amlodipine of 5, wow, I've doubled the lowering. And that's the same across all these different classes. You'll see that you can almost double the lowering by giving a second agent at half the max dose. So in summary, uncontrolled hypertension encompasses a variety of conditions, including microcode hypertension, non-adherence, and secondary hypertension. But when you really have true resistant hypertension, you need a multifaceted approach to treatment. So combination pills, enhanced lifestyle. Again, maybe there's a role for GLP-1 there, treatment of comorbidities like CKD, a role for combo SGLT2 inhibitors, and then newer agents, including those with longer duration of action, especially these sub-Q ones, can really make a big difference in pediatrics. And with that, I will end. Thank you for your attention.
Thank you, Tammy. So we had a great day yesterday, as others have mentioned, and great presentations to get this morning started off. And as Dr. Alexander mentioned earlier this morning, we are today because the development, of the development of drugs for the treatment of adults with hypertension that is not adequately controlled on other agents. And that provides us with the opportunity to also develop these products for pediatric patients. And we, FDA, have the authority to require sponsors to conduct the studies in pediatric patients. The issue, however, is that it's not clear what the unmet need is, how this population should be defined, pediatric population, down to what age uncontrolled hypertension occurs, and how much data, if any, can be leveraged or extrapolated from the adult to the pediatric population with uncontrolled hypertension. So, so based on the population that the drugs are being developed for in adults, the first question I wanted to ask the panelists is there an analogous pediatric population with an unmet need? So I understand that, the definitions are not, there isn't really a definition, as you mentioned in your presentation, for uncontrolled hypertension, but based on your practice, and if you, and also, maybe one issue is, and we should discuss this further, is, what does it mean for a pediatric patient to have uncontrolled hypertension? I think in the adult world, they have specific criteria, but the idea in general is that it's not uncontrolled, untreated hypertension. It's uncontrolled hypertension despite being on drug therapy. And so if we take a similar approach for pediatrics, it doesn't matter the number of medications, but just say not controlled despite being on other treatment or treatments. Is there an analogous pediatric population? What's your sense? Anyone?
I mean, I think, I'm thinking to patients that I've cared for we've had difficulty managing their blood pressure. I mean, I think it's always a balance between effectiveness of the therapy and the side effect profile. And sometimes that side effect profile is impacted by their other comorbidities or other agents that they're taking because of those comorbidities. I think about our transplant population, for instance. Getting to answer your question probably is to get what I would like to see in a perfect world would be to get to that group. And this would probably require a multi-center study. Clearly define who we're looking for in terms of those kids who have what we define as treatment-resistant hypertension. And then to do analyses, figuring out, looking at their pathophysiologic mechanisms driving their uncontrolled or treatment-resistant hypertension. Because I'm not quite sure, based upon what I've presented in my talk, is how much of it is RAS-mediated, is it RAS and sympathetic-mediated? Tammy did a wonderful job of summarizing newer agents and for the adults who have treatment resistant, but a lot of those primarily focus on RAS pathway inhibition. And is that the right approach? So I don't know that we'll have an answer without getting that population and looking closely at the population. That would be, my answer to that question. Identify the population, multi-center study, but the truly treatment resistant kids, and then look at that group and see what are the reasons why, in fact, they have treatment resistant hypertension. Because we can work to get, FDA approvals for, some of these direct inhibitors, but is that going to be the game changer for these kids? And I don't think we have an answer to that. We don't know that.
Right. So I guess understood, we don't know the underlying pathophysiology and whether it's the same etiology, et cetera. And so, it's not clear whether they would respond the same as adults would. But if you were to enroll patients in a trial today, right, like, who would that population be? What would that population be?
Well,
I don't know.
So I guess sort of, I will follow up with what she was saying and then hopefully ultimately get to answer the question. But I think for me, one of the bigger groups that are challenging and we need more studies in, and perhaps would lead to who I would enroll in a study, I would say are some of our youngest and lowest weight children. Because let's just say age 3 and under, because that's also going to feed into my blood pressure device comment, which I had to have one, right? But those under 3 are really the most vulnerable when it comes to high blood pressure, because there are, again, fewer agents for our use. They're all weight-based. And so if you have a really small 2-year-old and you want to do, even just sometimes the max dose doesn't really quite make the tablet that is already formulated, or when you're pulling up the med, it's like this teeny tiny amount. And then if they spit it up, did they get it? I don't know. And then if you try to put it in something they're drinking and they don't drink the whole thing, it can be really, really challenging to administer the right dose. Again, because they're small, they're weight-based. And again, for those of you who have children, infant and toddler, it's exceedingly hard to kind of manage life. And then now you're adding on a medicine that may have to be dosed multiple times a day. So I think those children are probably the most vulnerable and who need us the most. And then in addition, that makes it challenging. We talked about with uncontrolled hypertension, figuring out how much of that is white coat, and there's a lot of anxiety when you're that little and you're coming into the doctor's office, and we have no tools to assess out of office blood pressure in those kids. ABPMs, there's no cuff sizes and who's going to put that on a 2-year-old? I mean, maybe you would, right? Yeah, and they're too short. Yes. We don't have norms for them. And there are no devices really that you can buy over the counter that will be suitable for home blood pressure monitoring in that group. So I think there would be a hard group to do an outpatient study in, but I think if I could have a wish list and that would be a group that I would prioritize. And again, that group, those are the kids who are on dialysis or have advanced CKD or have congenital heart disease, maybe have diabetes. They're really vulnerable kids who need our help, and we just don't have a lot of tools in our toolbox or ways to help them monitor at home.
Okay. Pam, so Tammy, can I push you just a little bit more? So based on who you're seeing, the patients in your hypertension clinic, for example, right? Like, so Pam presented the Baxdrostat adult study for uncontrolled hypertension. That product is recently been approved for the treatment of adults with hypertension that is not adequately controlled despite being on other agents. So, sorry, if you were to think of an adult population that is not controlled adequately on other agents, do you think, based on the patients you see in your clinic, whether there is a pediatric population that is somewhat similar. It may not be that, that there is an unmet need for.
I mean, adolescents, they're emerging independents, and, they're spending a lot of time outside the home, and, so, or maybe even 10 and up. I mean, I think that that's when we start to get a lot of challenges in terms of blood pressure control, and that we need some additional agents. That's when, if we haven't done a good job helping prevent obesity, in the preceding years, that's when we really start to see rapid increases in their weight. And so using adjunctive therapies to help with that comorbid condition along with their blood pressure. So I think, that would be another group. And I see Joseph has his hand. I'd be really interested to hear what he has to say, but that's who I think, adolescents for sure.
Dr. Flynn?
So I think, as Tammy said, there are a small number of patients that might constitute a resistant group. I think of especially patients on dialysis and with advanced chronic kidney disease. I don't know that we have any idea right now how many young people with primary hypertension have the need for multiple medications. And I think that would, that's a knowledge gap that needs to be better fleshed out. But to get to your other question about, if you're going to do a trial, what kinds of patients would you put into it? I think that, instead of, requiring that patients have treatment resistant according to the adult criteria, you could, theoretically design a trial in which children on a stable dose of a single antihypertensive medication are not controlled on that medication, and then you enroll them in a trial of one of these other medications as add-on therapy. In other words, instead of, a child with lisinopril who's on lisinopril at 10 or 20 milligrams, blood pressure is still too high, instead of, adding amlodipine, which a lot of us might, or adding a beta blocker, you could take that young person and put them into a trial of one of these newer agents. So I think you could be a little creative in terms of the eligibility criteria for trials of these drugs in order to get pediatric data.
Okay, I'm gonna interject with something a little bit, again, as yesterday, a little bit afield. The law as written basically forces us to ask a question that maybe doesn't need to be asked. The point of these laws, as I understand it, is so that we can get.
Sorry.
I'm going to assume that people still want to hear what I have to say. But getting back to that, I think we're trying to squeeze a square peg into a round hole by forcing this idea of, multi-drug resistant, treatment resistant hypertension in children, and saying we have to find that because that's what the law compels companies to look at. You can imagine a scenario if a company had an adult indication for resistant hypertension because that's what the market indicated. That doesn't necessarily mean that that has to apply in children. You can imagine a scenario where a company might say, well, look, we would like to treat children just, as a primary treatment with, drug X, whatever it happens to be. We understand that this isn't necessarily completely aligned with what the law demands, but if the company were to say, we ask you, FDA, would you accept this approach as an alternative to what would be looking for, these needles in a haystack, these rare children, whether or not there's a huge unmet need. When the real unmet need is a broader selection of medicines available for children to treat. And it could be up to practitioners to decide if it's good for a primary use or secondary, add-on use in children. So I pose this, and this is, I guess, primarily directed at the regulators in the audience today.
I
Lynn?
mean, I think that's sort of what I was saying, although I guess not as initial therapy. But I don't think you would need to require, failure on 2 drugs or something like that, which has been some of the criteria for the adult studies, right? I think, as a second agent, that's a potential, there's a lot of kids that you could potentially enroll.
So
Yeah,
what
thank you. Go ahead, Shamir.
say I'm speaking for the FDA, but PRIA does allow some flexibility in how you assess drugs that are approved in adults. And we have multiple examples of where the actual specific indication that you see in adults is not necessarily exactly the same things that's studied in pediatric patients. So I think we do have some flexibility in terms of thinking of the hypertension space, in terms of how we define uncontrolled hypertension in pediatric patients. There is no currently accepted definition, has been noted with the people who presented today. And I do like the idea of Joe's suggestion is we don't have to be married to the idea that pediatric patients have to be on 2+ maximally dosed antihypertensives before they would qualify necessarily for a trial of uncontrolled hypertension. If you look at the actual indication at Baxdrostat, it actually doesn't say anything about treatment-resistant hypertension or give you the number of medications the adult needs to be on before starting the drug. Just says in combination with other antihypertensives, which may not be optimally controlling. And so we do have some flexibility within the PRIA legislation to work with, sponsors in terms of just exactly how they would define the pediatric equivalent condition to what's approved in adults for doing an assessment trial.
Can I just add one thing? And again, as a cardiologist, I think there's another important question to ask here. How much do we want to focus? And again, I know this workshop is about antihypertensives, so bear with me on this. But how much do we want to focus solely on hypertension versus the child's overall cardiovascular health? Because on one hand, and what I was bringing up in my presentation is that these associated comorbidities, I take us back to this CKM framework, which is the idea that for many kids, getting to hypertension proceeds through the development of dysfunctional adiposity. We have a big issue there, right? It's not just hypertension, but there's their lipid profile, it's OSA, metabolically active steatotic liver disease, all of these things that also contribute. So I do understand that there are times, in this conversation, we're thinking about additional antihypertensives, but I'm almost wondering, we have such a hard time getting things like GLP-1s, like, is there an opportunity to even think about multimodal therapy where it's not just, and again, I know hypertension, but maybe we need to think about, sort of multimodal therapies, because a lot of the kids, we can focus on that 1%, or 10%, we'll say 10%, but there's still the 90% whose cardiovascular disease profile is abysmal. And so I'll just put that out to the group, as a thought point.
Yeah, I mean, I hear you saying that, hypertension is complex, and there are so many things that contribute to why children are hypertensive, and that more needs to be addressed than just the drugs. So your point is well taken. Again, at FDA, for the purposes of this workshop, and I think some of those issues, are important also in the design of the trial to make sure that some of those things are optimized, maybe, when these patients are enrolled. But, mostly, of course, our job here is, drug development. And so that's what we're talking about. But your point is very, very well taken. Just 1 second. I just want to check with Lily if there's anything on the chat, or if anyone on the room has comments, or if Dr. Flynn has his hand raised. I also can't necessarily see that. So if you wouldn't mind just flagging those things for me. Go ahead, Lily.
There are a couple of questions. One is, since aldosterone synthase inhibitors have a new mechanism of action in adults, are there any developmental aspects that we should consider to choose the appropriate age if we plan to investigate these novel mechanisms of fear?
Someone want to take that?
All I can say is this, the person asking the question, this is a question that comes up from parents. They are you will get resistance as a provider, as a clinician, about prescribing medications in kids, particularly things like antihypertensives, because they can't see hypertension, right? They don't feel, in many cases, hypertension. And so parents will ask, well, what is this long-term impact going to be on my child? Now, they don't often ask the opposite, which is, what is the impact of uncontrolled hypertension on my child? And that's where we kind of shift gears. But I do think, as we think about drug development, and I think it was brought up multiple times here, there are inflection points in development of the child, kidney maturation, all sorts of just hormonal shifts, everything that's happening for this child across their lifespan. So if we intervene at one point versus another, are we more likely or less likely to have a detrimental effect? Are we more likely or less likely to maybe positively impact their overall trajectory, which is a question that I raised in my talk? We don't yet know. If I treat a young child with hypertension, choose your agent, may I then possibly affect in a positive way their overall blood pressure trajectory for the rest of their life? We don't know that. So I think whatever, and I'm so happy we have this workshop, because it's an initial conversation. But when we're thinking about trial design, when we're thinking about study population, different age groups, considering these developmental stages, and then I think we also need to think about long-term monitoring. 6 months is not going to answer a parent's question, right? 6 months of safety follow-up, right? They're not, 6 months is 6 months. They're like, what's this like for my child 10 years from now, 20 years from now? And I know those studies are expensive, but those are the questions that families ask. So some of that data, like for the pravastatin study, New England Journal, they were able to look, I think, retrospectively, right? So they had some data looking back. But I think you have to think about conducting some of those studies too, looking at long-term outcomes for some of the drugs maybe that we already have out there, and then thinking about, for the newer agents, designing processes for capturing data and best designed prospectively, so we know exactly what we want to capture. Neurodevelopmental outcomes came up, kidney outcomes, all of those things. Yeah.
Just to piggyback on what Dr. Smith said, with new mechanism of action drugs, safety considerations come to the forefront often. And that can start with non-clinical studies, because, as you said, it's very hard to do long-term safety studies in pediatric patients. The time horizon is just too long to get the drugs available. And so safety considerations that may start with non-clinical models and then move to inform clinical studies is often what's needed for new mechanism of action drugs, even if it may target similar part of the pathway. You still could have effects that are unexpected or off-target effects. And so I think what we look for as regulators becomes more for some of these types of agents with new mechanisms of actions versus well-established drugs in certain classes.
Sure. Hi, can you hear me?
No.
Okay, I'm going to try to speak louder.
Or Lily, you can come up here.
I don't know if it's the mic or my voice, but I think this is working out a little bit better. There's another question in the chat that was that Joseph responded to, but I thought it would be pertinent to raise it for the group. Would the pediatric hypertension community create an age-appropriate definition of treatment-resistant hypertension? And I thought maybe, Joseph, you would want to speak to your response and others could chime in.
Well, my response was just a citation to my paper that we wrote on treatment-resistant hypertension. And, I think the, I don't know that you need a specific pediatric definition, to be honest, because, treatment, it's really just hypertension that fails to respond to standard therapy. And or I guess that would be resistant hypertension. And I think one of the issues is just being able to even identify patients who are truly treatment resistant. So, use of ambulatory blood pressure monitoring and change, as Tammy was, mentioning, more use of combination products. Those things may actually, whittle down the number of patients who truly are not responding. And so, I'm not sure that we need to have a specific pediatric definition, except, the principles are similar, I would say. And I don't know what, Tammy or Carissa or someone else might have to say.
Tammy, go ahead.
Yeah, well, I just want to share. So as we had our preparatory meetings for this workshop, I realized that I didn't fully appreciate the difference in definition between uncontrolled and resistant, because in my clinical brain, I sort of thought of it all together. And which is why in my talk, I tried to have a very, very purposeful slide about what uncontrolled hypertension encompasses. And I'll just put a little plug to Dr. Flynn and Dr. Baker-Smith that with the next iteration of guidelines, perhaps we can be a little bit clear about uncontrolled hypertension, not maybe defining it, but just saying these are some of the things that encompass uncontrolled hypertension. Because I think we kind of know this as clinicians, right? And so, I mean, when I see somebody like I was sharing earlier with blood pressure that's not controlled, I go down my list, adherence, maybe I should do a little bit better job of the white coat hypertension part. And then certainly if you have somebody brand new and they're really not responding the way you expect, then I maybe move to the more invasive tests to look for secondary causes, which is really ingrained in pediatrics. So in my opinion, I think we look for that a little bit more, perhaps, than the adults. So I think, being, strict about, this is what uncontrolled hypertension is, more than one med or whatever, I don't think that's as important as kind of raising the awareness that, when kids are not responding the way you might think, these are the four kind of things you might want to think about, maybe addressing the comorbidities, and then that'll allow us maybe to kind of come at it with a multifaceted approach to management. It just, sometimes you just need to see it written down to really, I don't know, I'm visual, but like I need to see it written down and just clearly laid out to kind of really think, oh yeah, that is how I think about it. And actually, and it helps me think through the next patient. I don't know, but it was eye-opening. I actually had a little on the call when I realized the difference between uncontrolled and resistant, especially when it comes to the FDA and indications. I think that's really important to think about. So
I just want to add to that. The reason why I'm kind of focusing on that definition, I do participate in different clinical trials, and often you see that sort of Hawthorne effect, right? So you're like, oh yeah, this patient meets inclusion criteria, and as soon as you're getting ready to enroll them, like to add this extra therapy, suddenly their level, whatever you're measuring, is now well within normal limits, right? And then as soon as they're no longer being considered for enrollment in the trial, then it's back, right? So I think just practically, if we're not very clear on how we're defining this group, we're going to have a lot of screen failures, right? You're going to spend more money probably, and not that it's about money, but because we are trying to get to a population who actually needs these additional therapeutic options. But I mention that because going through this for a different condition, we see this. And so, and it gets back to a lot of these conditions in kids. Congenital heart disease is very different. I would argue probably CKD, especially if advanced, is different, right? Visibly, you can see the child looks sick, or there's something wrong, right, I should say. But then if it's, stage 2 hypertension, they're not really symptomatic. Stage 1 for sure, dyslipidemia, things like that. They don't see it. They don't feel it. And so the compliance is the issue. So to get to the heart of our question, which I think you raised in terms of what is the pathophysiology and what mechanisms of drugs do we need to promote, maybe one more than the other. I do think it's important for us to get to what is that population. And the only way we're going to do that is to have a systematic approach, going through the checklist, getting to that group. Now, that's a separate question than how do we test the safety and efficacy of these newer agents in the pediatric population. If the question is just testing the safety and efficacy of a new therapy, then you don't have to be as selective, right? I mean, maybe it's just an alternative therapy. It's kind of nice if you don't have to take a drug every day, right? So these mRNA, like we've got inclisiran on the lipid side, but having an agent that you take every 6 months might appeal to somebody. I still think, though, we're going to get to questions from families about long-term safety, impact on development, those things. So, whatever we can do. And congenital heart disease, they have some, sophisticated, but models and tools for assessing neurodevelopmental outcomes. We might want to think about adding some of to the trial design for these drugs. But just to reiterate, concluding point, 2 separate questions: pathophysiologic mechanism of treatment resistant hypertension, who's most likely to benefit from these additional therapies, very different than just wanting to test just the safety and efficacy, I think, of these therapeutic options. Yeah.
Okay. I wanted to just raise, just pivot a little bit and build on something that Dr. Flynn said about, potentially thinking about uncontrolled hypertension in pediatric patients as those that, despite taking one agent, remain hypertensive, right? And so this is a subset of the overall population with hypertension. And so do you think that this subset, so we had a long discussion yesterday about chronic hypertension, but do you think that this subset fundamentally is different than the overall population and different from the adult population, or are they pretty similar that we could take a similar approach as what we discussed yesterday, in the sense that we think that, for multiple products based on all the pediatric studies that were done, they reduce blood pressure. We think that's important, and that's an indication that, yes, they work in kids also, like they do in adults. And so would you take a similar approach to this subset, or is this subset different?
I like your question, and it gets to a point that Tammy raised. I think, so there's obviously the trial design questions and drug development and safety efficacy assessment. Then there's the practical aspect, right? So to your point about, and maybe it's a slightly different, just a shade off, but I do think, to answer your question, I do think that there are, when we see that kids don't respond to one agent, I do think it's a difference. There's a different subset, right? At least that's my opinion, because I know that in, adults, it's very common for them to be on 3 or more medications for control. When it comes to pediatrics, though, the other thing that we have to think about is the practical aspect of bringing them back and assessments and the face-to-face time with the provider. So if there's an opportunity to put in place a pharmacologic intervention that is very effective, such that you're not having to dose increase 5 milligrams to 10 milligrams of amlodipine. Maybe it's just one dose of this newer therapeutic option, fewer visits with the provider, that might be a more effective option too. I don't know if that makes sense, but it's where we get into trouble with hypertension diagnosis in kids is the number of steps we've required to make the diagnosis. You confirm it, and then treatment adds another set of visits and contact that also impacts our ability to treat these kids. So if the more times we have to bring certain subsets of the population back into the office, the less likely you are to be able to control their blood pressure. The more effective the therapy with one dose, the less without side effect, the more effective I think will be too. So I know it's a slightly different answer to the question you raised, but I do think, yes, these kids are a little different. And I want to add one point to that, and then I'll stop talking. The other thing to think about with these other comorbidities, like the sleep apnea, kids don't like to wear CPAP. So if I've got a kid who has obesity class 3, has sleep apnea, has hypertension, has LVH, eccentric hypertrophy, has dyslipidemia of obesity. Look, they've got a lot of stuff going on, pre-diabetes or diabetes. They're not going to let them wear the CPAP. They don't often like to wear the CPAP. That might have helped their blood pressure. They may not be able to get the GLP-1s, which is why I brought up multimodality therapies. And then if I can put them on an agent to control their blood pressure, but I don't have to bring them back as often, that might be effective. That might be an option. Anyway, I'll stop, and maybe other people can weigh in there.
Go ahead, Dr. Burckart.
So let me just kind of bring this back in terms of the complexity of the disease. I mean, we're kind of heading in a direction here where this is very unique, and we don't have any other examples in pediatrics. But thinking about it from an extrapolation standpoint, I think we do have examples of very complex multimodal diseases in which we've been able to kind of bridge to extrapolation from the adult experience to the pediatric experience. Now, this is when we had the initial extrapolation committee in Cedar, and 15 years ago, we insisted that the pathophysiology be exactly the same in the adult disease and the pediatric disease. And I think the awakening was really with juvenile rheumatoid arthritis, where the secondary mediators, of which there are multiple, can be approached from a drug standpoint, and irregardless of the underlying pathophysiology. And so I think I think we would think about this in the same way, and that yes, there may be multiple pathophysiologic mechanisms for what we're talking about, but in fact, interrupting one of those mechanisms may have a positive outcome in the patient. And that's what we're really looking for. And I think that's what you can show. You can probably, you can show it in adults, and I think correspondingly, you can show it in kids.
Just to expand on that a little bit, like thinking of for the perspective of a company, is it sufficient for a company to show that a medicine is effective in children, and then it's up to practitioners to use it in a way that they see fit? Or is it sufficient for a company to have to basically put the package together, put the whole thing together to say that, okay, this is the way that it should be used in this subpopulation of kids? My way of thinking is, I think I would lean toward the practitioners having more freedom to do it, and that what the companies need to do is to show that a drug is safe and effective, and not necessarily prescribe or have it built up in the manner of it being studied to kind of narrow how it ought to be used by practitioners.
Yeah,
I would love that.
Yeah, I
Yes.
also think, I mean, just Tammy, one of the issues related to what you just said, Frez, is that, how we define certain things or how we think about certain things change over time. And so you don't necessarily want to be boxed in by, a very granular, specific definition of something, right? Like if I think, things evolve, our knowledge evolves. Sorry, Tammy, go ahead.
So I just wanted to touch upon the question earlier, which sort of we've been skirting around a little bit. But in terms of when you asked if there's anything different about kids who have uncontrolled hypertension than in adults, I think the one thing that we need to be mindful of is that in kids, we're much more likely to have secondary hypertension than maybe in adults. I know that that's, that prevalence of secondary hypertension and uncontrolled hypertension in adults is evolving, especially now that we're recognizing primary hyperaldosteronism is likely under-recognized in adults. But that 5 to 20% of uncontrolled hypertension in adults being related to secondary hypertension, I don't know that I have the data, but I suspect it's much higher. So if we're thinking about, before I was like, let's not give it a definition, but if I'm thinking about it for a drug, when you have uncontrolled hypertension in a pediatric patient, you really should make sure there's no secondary cause first before enrolling them in a study, because that pathophysiology is different. I think in adults, like let's say it's 5%, if some of those people get through into your trial, it's not as big of a deal, perhaps, as if 20% of your population in their trial has undiagnosed secondary hypertension, because then your drug is going to not maybe work. Maybe you won't be really testing what you're intending to test. So I think that's one thing in peds that's a little different.
Yeah, and I think Pam can speak to this, in the adult trial. I think those were some of the issues they considered in terms of secondary hypertension and excluded some of those populations in the adult trial.
Yeah, certainly. So I think, Tammy, I think you bring up some really good points, and I'm wondering. One of the things that I'm worried about, of course, is safety in a developing kidney, right? And we have, what can we do to mitigate that? Well, we have adult data, right? But our adult data, as you say, is primarily is mainly in a primary hypertension population. And even though it's not, I think it was Joshua who mentioned yesterday, it's not really a matter of age, but it's a matter of etiology, right? So is that a comparable population? But the other thing that I mentioned before was safety in a, when you look at safety in a developing kidney, so I have adult data, but that's not in a developing kidney. I can look at older kids. Again, that's not necessarily, depending on your cutoff, that's not necessarily in a developing kidney. So what can I do? So first of all, what do I need before you're comfortable going into a developing kidney? So at what age? And how do I gather that data if I know I'm not going to get that from my adult population or my older kids? So,
Great.
So what I'll say is and I agree with Tammy, as you get into uncontrolled hypertension realm in pediatrics, even if it's just not being controlled on one drug, and you go down in age, the proportion of patients with secondary hypertension as their cause will go up dramatically. At the same time, there's going to be a tension between limiting a population to one that doesn't have secondary hypertension and generalizability of the indication. We want these drugs available to as many kids as we think it's safe and effective to provide them. And as Tammy said, if we want to develop some of these newer mechanism drugs in younger patients, we should be investigating kids with secondary hypertension, for which we think the drug will be effective and safe. Ultimately, we want to reduce the blood pressure. Certainly, there's a very small subset of secondary hypertension in pediatrics that may be monogenic or other causes where a very specific different drug with a different mechanism of action is the treatment of choice. But say secondary hypertension due to CKD or maybe renal vascular hypertension that can't be corrected, with our interventional radiologists, these newer mechanism of action drugs may provide actual benefit in blood pressure lowering, which is what we're after. So we have to kind of balance studying a population that we think is really truly primary hypertension versus the reality of what uncontrolled or resistant hypertension looks like in younger pediatric patients, where secondary causes are going to be a significant proportion of the population.
And it seems like, go ahead, Gil.
So I wanted to comment on the long-term use. I mean, these drugs are obviously intended for long-term use, but that's not too much different than most of the drugs that we approve for use in pediatrics. Over 50% of them are for chronic use, as FDA defines chronic use of 6 months or greater. And so consequently, there is going to be a discussion, I think, in the agency and with outside groups about how we should be monitoring these drugs long-term. Our preclinical, as Shamir mentioned earlier, we do have some preclinical ways of looking at drug safety, but they're most effective only for a small number of drugs, and most of the juvenile animal studies that we do are not, don't make it to the level of being in the label, for example, or having an effect. And so we need some way of long-term monitoring. Right now, we do a 1-year open label follow-up study, and we're not sure whether that really tells us what we need. Probably from a developmental standpoint, it does not. And so we definitely are going to have a discussion about from the long-term standpoint about the drugs we have available and new drugs, about how we're going to be able to look at safety features and developmental safety long-term. It could go to registries, for example. We have specific, the most of the experience in pediatric patients is with specific diseases, cystic fibrosis patients, for example. The Cystic Fibrosis Foundation has had registries for the last 30 years. So I don't know if that's one of our options, but we definitely, that is a discussion that we need to have.
So I'm hearing there's safety concerns with newer agents, especially with longer term use that need to be addressed. And that also, absent safety concerns for including pediatric, that we see more, as we getting into this realm of uncontrolled hypertension in pediatrics, we're more likely to see secondary hypertension, but that absent safety concerns, you would want to be inclusive of a broader population. I want to just circle back to Dr. Flynn, since we're talking about population. So you said earlier that, you think that many of these pediatric patients who are uncontrolled, meaning that they may not be adequately controlled despite being on at least one medication, tend to be patients on dialysis or with advanced chronic kidney disease. And that we don't really know in the other populations outside of that, how many could have, uncontrolled hypertension. So do some of these, some products, for example, if they're targeting the renin-angiotensin-aldosterone system, obviously hyperkalemia is an issue, and ASAPs even, have a warning or not really indicated in patients with a GFR less than 30. So do you think that outside of dialysis or outside of really advanced CKD, if these populations are being excluded, for example, in adult trials, do you think there is a pediatric population with unmet need that could be studied?
Well, I don't. Let me answer your question in a little different way. I think that the number of children and adolescents with hypertension who require more than one drug is high. And even in those who you believe you've excluded secondary causes and you believe you're treating primary hypertension, I think, in any, pediatric hypertension clinic, I bet you a big percentage of them are on more than one drug. So, you know, and so from a perspective of, you know, finding patients to put in a trial, if we change, if we, as we were saying before, I think you would be able to find patients. Now, getting to your point about, you know, hyperkalemia and that with advanced CKD or dialysis patients, well, sure, that is a concern, and we would, you know, need to have the close monitoring of those kids for that, you know, side effect. And but aside from that, I mean, I think even, you know, to find, right, I think there's a tension between this sort of uncontrolled hypertension and resistant hypertension. Those are two sort of different concepts, right? So there's lots of patients out there. In fact, if you look at, you know, adults, you know, most patients who are hypertensive are uncontrolled because control rates are low in the US. And so, and I think you would probably find the same thing in a pediatric hypertension practice, that there are a large number of patients who are uncontrolled. So that's a different group of patients, right, than those who are truly treatment resistant, you know, strictly defined. And so I think, you know, that group in pediatrics, I think is quite exceedingly small. And thank you to Susan Menley in the chat who put in there the new term that we had proposed, apparent treatment resistance of childhood, or what was it, right? Apparent resistant hypertension of childhood, because we don't know in some of these kids whether all of those criteria for truly resistant hypertension are going to be met if you strictly define it. Well, let me stop there because I think I'm sort of getting off on a tangent. And is there a part of your question that I didn't really answer? I feel like there probably is.
Yeah, I think I think that was helpful, Dr. Flynn. Thank you. Yes, Tammy, I wanted to go, Tammy, before 1 second. I think Chris had a comment. I didn't want to bypass her. Go ahead, Chris.
One of the things to point out, you know, I'm putting my design hat on because I'm hearing all of this, and I did want to just have a comment with respect to titrations and the annoyance of having to come back or even have contact with your physician about de-escalating. Not that's something that we actively think about on the drug development side, and having fewer titrations is just one. It's like, way to go. So I just want to let you know we're on it even on the adult side, because we hear the same thing from providers. Like, I have to call them, leave a voice message, they call back, I'm not in the office, blah blah blah. So we're on it. With respect to the primary versus secondary hypertension, I think one of the other things to keep in mind is that pediatric trials, we try to be even more sparing with patients than with the adult trials. So not only are you causing this to just be higher in prevalence, but also your studies are a lot smaller. So these differences can change the results of your studies a lot more dramatically than adults. And so even if we wanted to generalize, well, we need to think about, is this a stratification factor? Is this something that we want to predefine so that we do know how to interpret our data? And I'd love to hear your thoughts on that. But before I pause and let you talk, the other thing that I want to ask is this whole, I heard yesterday a call to duty on please develop drugs for hypertension all the way down to 6 years old. Have it in your plan. Think about it proactively. I think people hate it when I come to meetings because they're like, oh my God, just gonna talk about peds and we're talking about adults. Well, but I'm like, they're here. I'm willing to like do this on the behalf of the cause. Can we do studies, maybe indication agnostic, or I want to hear your opinion specifically on hypertension, 6 to 18? Or do you think there is an important cutoff that we need to be thinking about this 6 to 18-year-old group, because we typically do have the 6 to 11, 12 to 18. It adds to the development time, it adds to their operational complexities. Tell me about that second question, how do we make this more efficient? And how do we do this from a regulatory standpoint, a clinical perspective also? So those are my two things, subsets of different hypertensions, and then also this bucket of 6 to 18.
It's almost like you were reading my mind because I wanted to answer the question, your first question before you asked it. So, but that was I just wanted to clarify my comment about the importance of recognizing which children in the uncontrolled hypertensive bucket have secondary hypertension. Not because I want to exclude them and not have these tools in my toolbox for them, but recognizing the problems with study design. If you're diluting your patient population with those who have a different mechanism of action and you don't see the effect that you want, is it because the drug's not effective in kids without secondary hypertension? Or is it you've had too many kids with secondary hypertension who need a different method to lower their blood pressure? Like with I mean, it would be obvious you have a dialysis patient, but you want to have better fluid removal, right? If you have somebody who's fluid overloaded, and then you're trying something that doesn't work on that pathway, it may not lower the blood pressure in the way you have it. And again, to your point, you want to be as efficient as possible with enrolling as few kids as possible because of the burden and the risk-benefit ratio for kids participating in trials. So I did want to put a caveat to my earlier statement, and we just got to be thoughtful in our design and perhaps stratifying, although that adds sample size, but just being thoughtful in our design so that at the end of the day, when you're analyzing your data, you're not stuck with, well, that's not what I was expected. And again, thinking about the slide I had with that one agent that worked very differently with different agents, right? If you, at the end of the day, you have a 5 millimeter mercury difference in blood pressure reduction or 13, I mean, obviously you'd be happier with the 13, and you don't want to, again, dilute your results because your patient population is such that it would. But I'll let others answer the other question. I'll stop there. I can also keep going. So, so I mean, did you? Okay. I think so. To your point about the pediatric population, 6 to 12 or 12, 6 to 18. So, puberty, that's a big maturational change, and particularly in pediatrics, if you have any, this is the time I tell families who have CKD, the two biggest challenges to the kidney is toddlerhood and teenagers, because they have rapid growth. And then if we're going to be able to see at the end of, as you emerge from puberty, like how much kidney function you ultimately are with because of the nephron endowment that you have at that, at that time, or with progression. So there's a potential, especially if you were wanting to have the indication open to those with CKD, that you may have a difference in efficacy or maybe even safety in that kind of teenager age group. In addition, that's where, there's their cognitive development is also really escalating in that time period. And so, and their ability to be vocal about side effects, you know what I mean, and being able to be empowered and to share those kinds of things. So it does make sense to potentially look at them separately. But I recognize the, I'd have to really do, look into a literature search to see how much of that would impact the outcomes to make you design your study in such a way, since it would add complexity. So that part for me is still a little unknown, but there's enough theoretical that could contribute to wanting to look at two different groups.
Yeah, I think, and this is Carissa, I think that, obviously, as you asked the question, in lipid studies, we tend to break it up as well. So usually it's approval 18 and above, and then they do 12 to 17, and then it's 6 to 11, and then under 6. I guess my question, I punted back to you because I'm wondering, is it you do 6 to 18, but then you have secondary analyses. So you design the study such that you are able to ensure sufficient power for the two subgroup analysis, so that costs and other things maybe for enrolling and inclusion, and you have this person who's like just turning 12, but you know what I mean, like you're able to include those kids. There was a comment made, and I'm not a nephrologist, but about kidney maturation, I think up to like 8 or so. So maybe that's something that factors in. I don't know, final kidney maturation, I don't know. Oh, just final at 2. I thought there was somebody who made a comment up to age 8. There's something else that was happening up to GFR or something up to age 8. No, just 2. Okay. So if there's no other developmental issues with the kidney, then I think it's probably fine. But yeah, if you had a 6 to 18 and had the ability to do subgroup analyses if need be for the different the 2 other age groups, I think that's fine.
Could I ask, is Ricardo, are you, was that, was it GFR maturation to, to adult levels at around 2? And then Ricardo, I thought you, yes. Transporter maturation until, was it 8, you said? Was that the?
Oat transporters. Oh,
Did you want to?
yeah, tubular oat transporters mature,
Right, somewhere the
later.
GFR, I think.
Yep.
Yes.
Those few 8 years.
Yeah, I was thinking with what was discussed, if we go to a group of patients 6 to 17 years of age with obesity, who are not responding to maximum dose of an antihypertensive drug, most likely RAS blockade, or amlodipine, but it has to be on maximum dose. When we randomize this patient stratified by age, 12 years of age, which take care of adolescent, going to puberty, and then do the study, and with the new drug. I'd be very uncomfortable as a first study to study kids with CKD with impaired renal function as a first study. That can be done later on. But as a first study, I think I would go to that population, exclude somebody with bilateral renal artery stenosis and things that, and we need follow potassium, of course, if you're using aldosterone synthesis inhibitors. And we follow those patients with ACE inhibitors and RAS blockade in general. So that's something to think about.
So I'll chime in on this question. I personally get a little nervous. So what I'm going to preface my comments and state that I'm talking about new mechanism of action, first-in-class drugs for hypertension, not some of the ones we've been discussing already. I get a little nervous about initiating trials in pediatric patients until there's some, I'll say proof of concept, that's not really the right term, some preliminary efficacy data in adults. And that can be from early phase studies like phase 2 trials. And then a consideration of what unique safety concerns may develop in pediatric patients, whether that's things surrounding puberty and adolescence or specific safety, potential safety concerns in like the 6 to 3 pubescent population. And there, I think there's ways to surmount some of this and still include the patients within the concept of a larger, phase 3 trial. It may be that you have to stagger the enrollment. Maybe that you have to first show some efficacy in adults, collect some safety data in adults, and then move to subsequently younger cohorts, all the while looking at the data, looking at the safety before you go to, first in adolescents, before you go to the younger patient populations. So yes, you're right. Traditionally, new first-in-class drugs are first approved in adults, and then you move to pediatric studies. It doesn't always have to be that way, but you really have to underpin that with some efficacy data and a really pretty good understanding of what you think the potential safety concerns may be in pediatric populations, so you can build those strategies for evaluating, assessing, and mitigating those within the trial itself.
Go ahead, Lynn.
Before you move on, can I just ask for a recap, because I'm getting a little lost. So if we're talking about uncontrolled hypertension, what I heard was, look, we have some flexibility here in defining what that population might be. And what I heard was that there is a population of pediatric patients who need more than one drug, who we would consider uncontrolled, and that would be a population we could study. Did I hear that right?
Yeah,
Okay,
I heard
that's the
that
first
too.
thing. The second
Yes.
thing that I heard, and I wasn't sure I heard this, is we somehow started focusing on 6 and above, but are we really talking about just 6 and above? Is there a population who are uncontrolled? I think Tammy talked about at the beginning,
3.
the youngest population who maybe would benefit the most. So what age groups are we talking about who might need more than one drug, who we would consider a population that could be enrolled in a study for uncontrolled hypertension if we're using those criteria? Are we talking about down to 1 month? Are we talking about 1 year? I mean, we kind of agreed yesterday, kind of 1 year. Below that, it's kind of hard.
Right.
Are we talking about the same or are we not?
Yeah.
Yeah, I mean, I think that the uncontrolled hypertension in under 6 is absolutely a population we need to focus on. I think there, to the point about secondary hypertension versus not, we really need to pay attention to that because again, the way that the drugs will work may be differently. Although you might argue that the majority of those kids would have secondary hypertension. So you just need to be thoughtful about design and about categorizing the kids. But those are the ones truly that are the most vulnerable. We have so few options, and likely do need more than one agent. Yeah.
So then can I probe one more time?
Yes, please.
So yesterday we talked about, primarily pediatric hypertension, particularly in the less than 6 being secondary. But we had some data that suggested that, exposure responses were not different between the CKD and non-CKD population as an initial treatment. And I get that new molecules that are being developed may have special safety concerns. Baxdrostat being, a very good example of concerns about safety when you have GFR less than whatever, stage 3, right? Right? So that being an issue related to drug-specific concern, are we saying that we don't want CKD patients enrolled in an uncontrolled hypertension study, or that we have to stratify that we can get interpretable data in that subpopulation? Because I worry that becomes infeasible.
Yeah, I mean, those are the kids that really need it. So I
Right.
guess I don't mean to indicate that we shouldn't.
Okay.
I'm just trying, I'm trying to think at the end of the day, if the results aren't what we expected, we just want to be able to a priori have a plan in place to explore why that might not be the case. Because a kid with CKD 2 or 3A, may respond differently to somebody who has BPD, and that's the cause, or chronic lung disease, or what have you. And just so that, again, at the end of the day, if it's not what we expect, we have a plan in place. We hypothesize it might perform differently in these groups. But those are the ones who need it, for sure.
So are we saying down to 1 year of age based on the fact that we can't, we really don't understand or really don't know how to diagnose hypertension, or even there are challenges with diagnosing hypertension and checking blood pressures in these really young kids less than 1, and maybe that needs to be a whole separate workshop. Is that what I'm hearing?
I think the problem is that we don't know how to. It's not that we don't know how to diagnose hypertension. It's just that it's a little. The thresholds we use maybe are a little unclear. There are some kids who are clearly above the 99th percentile, and we know that they're hypertensive, so that's not ambiguous. But when they're 95th, and again, 95th percentile in 1 and up, that's hypertension when it's sustained. But I don't know that we know for sure in the littles, if that's truly. Should we be looking at the map? Because that's what, they're all getting, automated devices, and the map is a little bit more of a measurement that these devices give you versus the estimated systolic and diastolic from the proprietary algorithm. Should we be doing that? So I think that part's a little unclear, but when it's high, and it's unambiguous, we can absolutely diagnose neonatal hypertension. I just think it just gets a little challenging, the threshold.
Go ahead, Lynn.
I don't want to jump the gun. But
No,
maybe
please
I'm gonna
do.
jump the gun. So
No, please do.
So then the question becomes just kind of a follow on from yesterday. So we've identified a population that we think could benefit. We've identified the kind of age of that population. So then the next question becomes, what does the study look like?
Right.
Yesterday, we said that, look, for these classes that we know a lot about, we said, look, PK in a prevalent population and review the safety that's already been collected from many, many years of use. And maybe you have a package that would be supportive of, FDA review. What are we talking about here? Are we talking about randomized withdrawal design in a new agent? What are we talking about here? Do we have similarities here in uncontrolled, between pediatrics and adults that we could consider something less than that? Are we talking about, an externally controlled study? Do we even have, we have lots of data in controlled trials for first treatment hypertension, but uncontrolled, I'm not sure we have any controlled data on that. So I would love to hear from the group what they think about in terms of the study using sort of the benchmark is what we discussed yesterday, and why or why not you think it can be the same or why it needs to be different.
Yeah, and can I just add to that too? Like, I want to say, and some of the people who have maybe conducted the trials that we spoke about yesterday, that, that list where there were, it's an impressive number of patients that were enrolled in these trials, right? Like, so, and I'm pretty sure that many of those trials did not only include treatment naive patients. So some of those patients in those trials that, showed, and I'm not sure if those subgroup analyses have been done similar to CKD and non-CKD, but, in terms of treatment naive versus those that have already are already on another agent and not controlled. And then maybe, additional data that may help us to resolve this issue of, would we expect them to respond similarly or not? But anyway, go ahead, Tammy.
So I think, so I have some ideas and then ideas on how to determine feasibility of what I'm about to potentially suggest. And so I think particularly for the youngest, so under 1, as we've all talked about, blood pressure measurement is exceedingly difficult. And many times, while you certainly can do auscultatory measurements, I often clinically need to go with Doppler and I don't get a diastolic, right? And so I think for that population, ideally, we would have an invasive reference to assess efficacy and safety. And so then the question is, obviously, we're not going to put in an A line in these kids, so we would need to have a convenient sample of individuals who are already admitted to the hospital for another indication, and they happen to have an arterial line. And then we would need to think about, okay, so what are the conditions for which this child is admitted requiring an A line that we would permit in this study that we think would be generalizable to the population? Because again, when you're under 1, if you have hypertension, you likely have a secondary cause. So that population we might be using in a convenient sample of hospitalized infants might be the population we need, or maybe not. Maybe we're, we need them to be less sick, so to speak. So we need to think about that. And one way we could assess the feasibility of this approach would be, again, I was talking against registries for blood pressure measurement, but this is where this could be really helpful. And we'll call out Andrew South with Superhero. He maybe has this in his registry. We could look to see of individuals who are under 1, how many of them have an ART line and what are their comorbidities and and how many of them have been started on blood pressure medicines, just to get a landscape analysis, is across, because he's got multiple institutions enrolled in his registry. So are there even enough infants for us to consider this as a trial design? Because it may be dead in the water. There may not be enough. They may be too sick. And so then we would need to think innovatively about how to do this otherwise. But if there's a population of kids who have an ART line in and that might be able to be included, okay, so then maybe we can explore that. So that's just one thought of how we could potentially approach this. And then, the other thing to think about is, we could consider using MAP, right, with oscillometric devices, and we can, I'm working with the Amy Isoke group to help get better devices in kids under 1. And those are all of the blood pressure measuring devices validated in infants are tested against an invasive reference. And so they don't have an auscultatory method for less than 1. And so if we had a good automated device that we could potentially use for these trials, we could partner with industry, however, but then that might be another alternative. Mm-hmm. Right. Well, I'll keep talking. Some of the people want to say, yeah.
I think because the studies tended to be short and that we think about the complications of hypertension over long periods of time, I really think that we should explore more the idea of withdrawal and then reintroduction of medicines. With the advantage of if you have families and patients who have hypertension where withdrawal is part of the study, they're used to the rigmaroles of dealing with hypertension. They may be used to measuring blood pressure at home, and maybe we can take advantage of that to add to the data package in addition to office measured blood pressure. So I would strongly advocate thinking about that as a design, or at least a design consideration.
Yeah, and I think families would be pretty open to that. I have many families that self-withdraw as sort of a test. And then when their blood pressure is still high, it's something that it helps with buy-in that they really need the meds. But I do think that is a compelling study design for this patient population.
So do you mean, Tammy, and Frez, so these are patients who are already uncontrolled on at least one agent. Are you talking about a randomized withdrawal study, or you like for the previous antihypertensives, what have typically been conducted, or you're talking about something else?
So just as an example, I think if you look at the lorundrostat phase 3, you had adult patients who were withdrawn from whatever they were on. Then there was a standardized reintroduction of medicines according to what was the best practice. And then that was used as a baseline prior to whether or not they could be randomized, because a lot of participants ended up being controlled once they actually were taking medicines in a regimented way.
Right.
And I think that might be a way to approach it in children. Now, what you may find out is that if you do that in children, that there's going to be a lot of screen failures. I'm going to call them screen failures because they didn't make it to the phase of needing additional antihypertensive. But from a population standpoint, I think it would be a good demonstration of what the real unmet need is in this I want to say so-called population, but in this population of what we call uncontrolled hypertension. That is I'm not 100% sure if that's something a lot of companies would want to take on. Again, if you anticipate a high screen failure rate because you're actually getting kids treated, but from a public health standpoint, that's a really great thing that you can actually demonstrate that kids can be treated and would respond to treatment once actually done in a proper way.
So I just want to say, I need to stay on task. I was thinking not of uncontrolled hypertension as I was designing that withdrawal study. So I do have a little bit of pause when it comes to being on multiple agents. So I need to stay, I'll remember the task at hand, sorry.
Right. So I agree with a run-in period, right? You got to do a run-in period because if you don't need an extra drug, you don't need an extra drug. That is important, whatever trial design we use. But my question really is, do we need a controlled trial? And that question sort of is a loaded one because I want to know how much confidence do we have that uncontrolled hypertension in adults is similar to uncontrolled hypertension in children. And if we don't know that, we don't know that, right? And if we don't know that, then we have to say, then we're probably going to need controlled data. If we have some confidence, but not a lot of confidence, we might be able to leverage some of the adult data, but we'd have to think very carefully about how much adult data that would be. And a lot of times when you start talking about borrowing data, the adult data overwhelm the pediatric data, and then you're basically saying we're not using any of the pediatric data. So you have to be very careful of that. But the question is how, my question to the experts here is, how confident are we that uncontrolled hypertension, if you're not well controlled on one medicine and you need another medicine, how confident are we that if you get that second medicine, yeah, we think it's going to go down? Obviously we need to test that new medicine, but We don't think that a medicine that we're going to add on is not going to work. Like, right, that's the question. How much confidence do we have in a drug that works to bring down blood pressure in adult patients who's uncontrolled is likely to bring down blood pressure in a child who's uncontrolled? And if that's true, if we believe that that is likely to be true, then we could imagine different designs than a randomized control trial, which would really be needed then.
What I was thinking is that based on the discussion we had yesterday, if we can do the first study in 6 to 17 years of age, we can easily find 15 patients in 1 year to 6 years of age that we can do PK/PD study. And that's not a difficult task. And I think we can find those patients.
Similar, yeah.
It's 6 to, and then extrapolate from the information we get from the 6 to 17, we can extrapolate to younger age group.
The whole trial is 6 to 17.
No, we can do randomized control, randomized withdrawal. Randomized withdrawal. In the 6 to 17, we go to population who are on maximum dose of an antihypertensive and they're not responding. There's a high blood pressure. We do a randomized withdrawal study in that population. They can be, as I mentioned before, to get some data in these patients about the dose, about the, this is the first thing.
Without randomization.
And then you want to extrapolate from adult, you can't, because in adult, you have this patient have non-responding to 3 medications. And here you only have, because we don't have a definition for uncontrolled hypertension in pediatric.
We defined it as we need enough and more. That's how we define it.
Right.
That's why it's
As one or more.
Yeah, I mean, I think what was the point I was bringing up, it depends on the question being asked, but if we just need PK/PD data, then you just have, maybe 6 to 18 is okay. But I think you need that group, then you get the PK/PD data from that group. But if the question is about mechanism of pathophysiology, of treatment resistant, I still think that's different it's going to be different by age group, right? Because you're going to have under 6, more secondary hypertension. Depending on then the points you were bringing up, depending on if we go to under 1, right? It's different outpatient versus inpatient. So then, yeah, so like, because those are different groups.
That who presented it? Was it Pam? No, it was Tammy. We know the classes are being studied. They're aldosterone synthase.
Yes.
Right. They're direct renin inhibitors. Right. So if we're talking about those classes, those classes are being developed. What is different about the population of adults and children that would give you pause for those things?
Yeah, I think for those particular agents, I think 6 to 18, if we're just looking at PK/PD data, 6 to 18. The question I raised in my talk about uncontrolled hypertension treatment resistance, is it more sort of sympathetically mediated? Is it more RAS mediated? Maybe there's a bit of both, depending. So that's where how deep we want to get into the weeds. But if we just want to look at whether or not these particular agents that have been approved for use in adults can be used in kids, and we want to have some safety and efficacy data, then I think you take the 16 to 18-year-old group and you get PK/PD data for PK/PD, and then for safety efficacy, we probably could use the group that's determined to have uncontrolled hypertension on a single agent. I think that would work.
What?
6 to 18 though.
So Lynn, I just want to thank you for asking the question the way you did, because now my brain is working, I think, the way you wanted it to work. So I'm getting your question now. And I'm going to be bold and say, I don't think we need RCTs. I think that there is enough, because I think for me, and as I mentioned, trying to wrap my head around uncontrolled and resistant hypertension, I think my nerdy, sciencey self would love to know how much it drops it by, and I would love to know certain things, but do I really need to know those things in order to prescribe it? No. What I need to know is what dose can I give? So the pharmacokinetic and dynamic studies would be really helpful with that. And then certainly the safety data, do these things cause more hyperkalemia or what have you, which doesn't need to be randomized controlled trial necessarily. It could be, anyway, observed and open label. And so again, I'm being a little bit bold, but I do think, again, that would be a quicker path to me having these tools in my tool belt. Yeah, and then the dosing information is what's the question for me.
Yeah, I think that was my point. Like, it did not randomized. That was exactly my point. If that's the question, I think we just have to be clear about what is our question. And if it's just, and not to reiterate what you said, but if it's just safety and efficacy about these drugs that have been approved, then you choose pediatric population. If we want to know that they're effective as an additional therapy to an initially prescribed therapy in pediatric population, then you do that study. But yes, I agree. You don't need a control group to do that analysis.
I mean, to Lynn's question, I mean, I think it comes down to the regulatory aspect. You know, if you require some demonstration of efficacy to give a label or an indication, then what Dr. Schonenhart, outlined would be the way to go. If you don't require demonstration of efficacy in the specific population to give a label, then, what Carissa was, discussing would be sort of the option. So I think it really comes down to the regulatory standard and exactly what you need to be able to label the drugs for kids.
What I would like to
We
add here is that
asking,
once
Right.
you know the dose, and I agree with them, PKPD is mandatory here. And once you have safety information in each drug, even if individually, we know that although those kids may be a little bit different, their etiologies would not be that different. And once the drug is safe for use alone, knowing what are the safety flags that we have for each drug and knowing what could happen combining those drugs, if of course they have two same drugs cause hyperkalemia, you would try to avoid to use those two same drugs. But knowing the flags and knowing the dose, you can prescribe it. And you will monitor your patient. So I see that we are talking a lot about safety and safety in combining drugs. But I think that from a safety standpoint, once we know what are the safety flags to prescribing it alone, it would be easier for us to understand what we should avoid regarding the combination of drugs, because each will be we will be having those flags, and we will be aware of that.
Yeah, thanks, Ricardo. Can I just, so I really don't want it to be a regulatory question, because it's not fair to ask our experts at the table who aren't regulators to provide regulatory answers.
I'm a regulator. I'm kidding.
Yeah, no, I mean, you and Gil, the ones who are not regulators. So I will rely on Shamir and Gil, and Kirtida. But what we're looking for is the scientific rationale to base a regulatory decision. And that scientific rationale is, if you have controlled adult safety and efficacy data established in a program that was robust, that supported an approval of a drug for uncontrolled hypertension in adults, that kind of information is important to have, but it's not necessarily enough. If we don't think that the approval in an adult through a randomized controlled trial is enough, because we don't have confidence that, we don't know if that drug that got approved in adults through adequate and well-controlled trials and the safety was enough to support approval. We don't know that that's going to work in children. Then we have to establish that effectiveness independently. Right. But if we think that the adequate and well-controlled trials in adults support an understanding that, well, if it worked in adults, we think the diseases or the conditions are similar. Uncontrolled hypertension is similar in that we expect the drugs to work, then we could consider something less. And that's the question we're asking for is, when you have an adult approval, do you have confidence that we don't need to establish independent efficacy? And if we do, why are they different enough? And if we don't, why are they similar enough? That's really what we're trying to get at. The scientific question, not necessarily the regulatory one.
Guess I'll go on and oh, go ahead, Jennifer.
Okay, well, to be devil's advocate here, because I do primarily agree with most of what's being said. Most of the pediatric hypertension trials enrolled at least 300 patients. Even if they were second in class or third in class or fourth in class. And that's because you need to enroll about 300 kids to get an adverse event of 1%. And so we're not going to be able to see the adverse events of 1%. And, you know, to be devil's advocate, there are idiosyncratic reactions in children like verapamil, and, you know, there's some there's a whole list of psychiatric side effects of things like that are, you don't see in adults that are in children. So we're not going to see them unless we do some really long post-marketing surveillance. And I don't know how well that could be set up for adverse events. Has that ever happened where you don't do a controlled trial, but you have prolonged post-marketing surveillance if you're just doing extrapolation? Okay.
I mean, to Bill's point, what's long?
Yeah.
We get
Years. Not 6 months, but years. And, you know, most of these kids would be fairly simple to track compared to, you know, the run-of-the-mill patient enrolled in a trial, because they are all seen at tertiary care centers.
That's a separate situation.
But I'm just concerned about if it's a first-in-class agent, about these relatively rare side effects that you wouldn't pick up whatsoever. It's these idiosyncratic things that happen in kids, which are certainly there, and there's historical data about things that you wouldn't expect in adults, but that show up in kids.
Well, and to that point too, we talked about like neurodevelopmental assessments and impact across the lifespan. The to get a little bit into the weeds of what Dr. Lee was saying too, I'm wondering, you know, when we talk about the age range of 16 to 17, we start to lose kids at 17, right? If they transition out of primary children's facilities and get into adult, transition period we know that's a period where we tend to lose patients, right, as they're transitioning into adult care. So being able to capture that information is just something we'd have to think about in trial design as well, that 18 to 25 year age range. I was going to say something a little different. I mean, if we thought that the medications weren't likely to have a worse effect than in adults, then even more of thinking about just taking a group of kids who didn't respond to an initial therapy, adding, and then looking at efficacy and safety, I think would be reasonable. But then we do, like to Dr. Lee's point, have to think about some of these unexpected side effects, which we would be able to capture. And I'm glad that she provided the number, the 300 plus number, which again gets to points that we discussed about feasibility of study design. Because if you're looking at such a rare group of patients and you need that X number, you're either going to have a huge so many sites enrolling, or you're going to have to broaden the inclusion criteria to capture that number of kids, because it's 4 to 5% of kids we think have hypertension. So, yeah, so those are, I do think 2 parts to the long-term follow-up, probably some years of follow-up, whatever can be funded, but then, and there's groups that have done this successfully, but then you have that 20-year mark follow-up. You're going to need longer-term follow-up of outcomes to really make, I think, families and providers feel more comfortable with some of these agents and capture information about some of the existing drugs that we do use. I think that would be a gap that needs to be filled if we're going to do that work.
I'm going to step in here. So we are about 15 minutes over, and I think what will be really critical and helpful for us is to get an answer as best we can to the question that Lynn just posed at the end regarding the trial design. We heard a little bit about you think that PK/PD may be sufficient in patients over 6 years of age. But really, again, I'm going to pick on people because I think it's critical for us to try. And if we don't know, we don't know. I think that's okay to say too. But what are your thoughts on, how similar or different these diseases are? Uncontrolled hypertension on one or more agent to support pediatric extrapolation. What would you need from the pediatric study? Do you need efficacy controlled data? And down to what age? What about down to 1 year of age, the 1 to 6 year age group? Or is it similar to, hypertension in general, where yesterday we discussed that PK/PD, safety would be sufficient and we don't necessarily need a control arm. So I'm going to start with maybe Dr. Flynn online, if you can maybe provide your thoughts on that.
Well, I mean, I guess I have two minds of two sort of thoughts. I mean, I guess part of me would like to know how much these drugs would lower blood pressure, but then Tammy is right, where we would probably expect them to lower blood pressure since they lower blood pressure in adults. And so you could do like an open label long-term safety study, and how long, I guess, is open to question, with a small PK/PD study to be able to, work out the dosing. And certainly that would work down to, relatively young age. I wonder, we talked a lot about kidney maturation yesterday, and it's not finished until the age of 2. And so, if these drugs are having any kidney effects, you might want to do something different in those very young ones, to look more carefully at effects on kidney, and definitely you would need, PK data on those young ones also. But yeah, I guess that I'll stop there.
And just to clarify, Dr. Flynn, when you say PD, you mean effects on blood pressure?
No. I mean, so pharmacokinetic, pharmacodynamic, PD.
Yes.
Yeah, right. Is what, right, exactly. Some idea, but you don't need a big group for that, right? You can do that in a small cohort, a small number of participants.
Me.
And it's probably not a surprise, Dr. Flynn is my first and continual mentor, and I have a very identical thought process as he. But the thing I wanted to just emphasize, again, I don't ever look at the package insert to see, well, how much did this lower blood pressure in adults, and then make a decision. Like, does it lower blood pressure? Yes or no? Okay, I'm going to use it in this patient in this time. So again, the nerdy me wanting to know how much it lowers really isn't going to advance the field. And I do think that age 2 is an important inflection point. I know we keep talking about 1, but I think it's 2. And I think
especially if we're thinking about the pharmacodynamics, pharmacokinetics, and safety, right? Because this is, I'm remembering, uncontrolled hypertension, and some of these younger than 2 people may be on ACEs and ARBs, and if we're adding an agent that can also impact creatinine and potassium, that may have a really significant impact in that age group because they're not fully mature, their GFR, and so we would want to be especially careful in that group. And again, I think for me, it's the safety issue. And if we can think about, and I don't know, maybe there isn't anything, but innovative trial designs in which we can get the same type of sample size, getting that 1% adverse effects in a different manner, and just trying to be innovative with that and engaging people to think about that could be one way to do this. But anyway.
Yeah.
So I would suggest that the answer is in the E11A guidance. So just like we talked about, I presented yesterday morning, there are some very specific and detailed questions in there about the disease that you're trying, the patient population you're targeting, the mechanism of action of the drug, the pharmacodynamics and pharmacokinetics of the drug that you would expect in the patient population, the pediatric patient population you're targeting. And it's quite extensive to work through that, and we're having kind of a peripheral discussion here, but the devil's in the details, and the details are in answering those E11A questions. And so I think the group that got the E11A guidance together did a very good job, both in terms of questions related to efficacy and questions related to safety. And I think you've got to work through that to really to understand, how you would apply a clinical trial to the pediatric population.
I was just going to add to that I think, as you said, it's not a yes or no answer. And I think that you look at this as a continuum. And if the answer is no, according to the E11 guidelines, it is what is the most efficient population to allow you then to bridge this whole group of people. And I think I may have bummed everyone out by saying age 1 to 18 years old, but maybe there is that efficient study in age 6 to 18 that then would allow you to answer yes, 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 all the way down to 1 year of age. And so you do that study, and then you do some more creative things about not, your traditional randomized control trial for every other group. But as you go through the yes, 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 or no, 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 then think about what is that knowledge gap? How do I design to attack those questions and get there really, really efficiently? So I love this conversation. So.
All right. I think we may have reached the end. We way over, but really, really do appreciate the very robust conversation. I think this has been really helpful. Some slides. Okay. You want to use that? Most important is to thank. Yes. I think I have it on my list too, but I'm going to show these people. Okay, good. I got it. Okay. Okay. Plug it in. I think I'll just do these people. It's projected. I have all this. Okay. Yes, I have. She's not I have. We need to say anything.
I mean, it's up to you. I do have summary. I do have summary, but we're running so late. I don't know if it's worth it.
Yeah. All right.
That's the summary of just the panel.
All right. So I think it's I want to start by just briefly summarizing some of the panel discussion, if I can, and that is, based on the adult programs, is there a pediatric population that could benefit from drugs being developed for uncontrolled hypertension in adults? And that what we heard is that potentially we could define the population as those that are not controlled adequately on at least one agent. and need an additional agent. We may not necessarily need a strict definition of resistant hypertension, but in principle, similar to adults not optimally controlled despite despite other treatments. There were questions about secondary hypertension, that it may be more common. However, we think that, at least based on the discussions, that certain specifics may need to be taken into consideration for specific products, but that overall, a more broad population should be included in trials of uncontrolled hypertension, and that the age group that should be included, there was some discussion about whether the lower cutoff should be 1 year or 2 years of age. There was discussion that if there are concerns about effects on renal maturation, or CKD progression, then or other safety concerns, maybe that needs to be 2 years of age rather than 1 year of age. So some further discussion about that, but some idea that potentially 1 or 2, somewhere in that range, and that under 1, we're not quite there yet. And then study design considerations, we may not need randomized controlled trials, but PK, PD safety down to whatever age is appropriate, 1 or 2 years of age, because there is some confidence that if the product is approved and thought to be effective, or shown to be effective and safe in adults, that there's confidence that the drug will likely work in pediatric patients, and that there's need for longer-term safety data through either, especially for drugs with novel mechanisms of action. So those were, I think, the gist of something. It's a very complex, interesting. We covered a lot of topics, but really wanted to say thank you to all of you. I want to say a special thank you to Heather Buck, Michelle Pollack, Lily Mulugeta, and Michonne Payne from the Department of Pediatrics and Maternal Health at FDA. I don't think without them, we would be having this workshop, so thank you. I also want to say thank you to Dana Hamill, Keisha Robinson, and I apologize if I'm mispronouncing your names, Heather Matten, and Jim Pauley at the University of Maryland Center for Excellence in Regulatory Science and Innovation, who helped us put this workshop together. Thank you. I thank the audio-visual folks here for helping us navigate the issues we've had with sound, and also to make sure that all the presentations and everything went smoothly. So thank you to you. I thank all the speakers, the panelists, the planning committee, and all of you for attending and participating in this workshop, both in person and online. Thank you so much. I think this was very helpful for us. I hope it was for you too. If you're traveling, safe travels. Thank you. That concludes this workshop.
Thank you.